It's a pleasure to meet with you today to talk about, well, the passion of OOSS and of you, its members. I have always been inspired over the last 3 decades by your burning desire to provide the highest quality care at the lowest cost in a patient-centered environment. It works. It really does. I want to take a little look back before we look forward. When I started with OOSS in 1984, it's hard to believe, but there were fewer ASCs represented in this room than there were in the entire country. It's hard also to believe that the facility fee for the cataract operation was $336, and the professional fee was $2,500. And indeed, the only way that you could afford to do the cataract in the ASC was to cross-subsidize that facility fee with the professional fee. We look at today, and it's incredible. The cataract facility fee is $1,000. The professional fee is $600. Whoever would have thought that the surgery fee would be the loss leader for the facility payment? But this is the place, the facility. That's where you make your profits and you practice in a productive way. So we've made great progress over the years, but I've discovered as a lobbyist that under each rock is another snake. There are battles to fight, and more in keeping with the spirit of OOSS, more opportunities upon which to capitalize. In framing my remarks, I was thinking about, well, what's important to the OOSS member in the government relations arena? And over the course of the past decade, about every 3 years, we ask you to prioritize what you would like us to be doing for you. And in government, the list hasn't changed a lot, but I've provided it here. Obviously, we want to see payment rates expanded. We want to see reasonable and manageable quality reporting measures. We want to be subject to reasonable Medicare conditions for coverage, including architectural guidelines and the like. And recently, we've seen some interest on the Hill in equalizing the payment rates paid to hospitals and ASCs. And then the issue that always is high on the priority list, and one that we've been able to succeed with respect to our efforts, is to preserve physician ownership of ASCs. From 1983 to 2007, how were our rates established? Well, to be frank, they were basically pulled out of the air by CMS. And indeed, many ophthalmic procedures weren't even paid for when performed in the ASC. And today, after we've lobbied for a more sane and equitable system, a number of things have happened that are good. Hospital and ASC rates are linked. As theirs go up, so do ours. We're not pleased with the fact that our rates are about 55% of the hospital rates, but they do go up. Virtually every eye procedure is on the ASC list, something we sought for 30 years, and now we're there. And we do get annual updates now. We didn't for many years, although they certainly aren't as high as we'd like, and we'll come back to that in a little while. So let's take a look at the rates for the bread and butter procedures. And look at the third column, which compares 2007 rates with the 2014 rates that are in the fifth column. We have enjoyed modest increases. We're not happy with those increases, but it's important to note that ASC rates, unlike that of physicians and virtually every other provider, our rates haven't declined. And when we take a look at reimbursement for corneal and retina and glaucoma, services, the rates for which were ridiculously low for over 2 decades, the increases have been very substantial, in some instances as high as 80 to 90%. And what we're finding through our surveys of you, our OOSS members, is that entrepreneurial and opportunistic as you are, surveys show that these procedures are now being moved into the ASC. So what's our primary priority? Our main priority is always ASC payment rates. And for the last 6 years, we have sought a change in the annual update that we receive. Hospitals receive what is called the hospital market basket, and ASCs receive the CPIU, the Consumer Price Index. There's about a point difference between the two, and the hospitals are getting a benefit here. And it's having a number of effects that make little sense. We're treating the same patients, consuming the same resources, incurring the same costs as hospital outpatient departments. It doesn't make sense to have a different rate. And the difference in these inflators exacerbates the gap in payment between ASCs and hospitals. We are going to press very hard this year, as we have in the past, for these rates, for our update to be at the higher hospital market basket rate. There's a new phenomenon. There's a new concept. There's something new and exciting happening on Capitol Hill now. And the most important development, I think, on terms of payment, is this notion of leveling the playing field between hospitals and ASCs. And before this ball got rolling, when MedPAC advanced this intriguing idea a couple of years ago, they were basically suggesting that hospitals should be paid the same as the ASC for those services that are performed frequently in ASCs, for which there typically is not an ER visit, and where the patient's severity is no greater in the hospital outpatient department and in the ASC. And that would basically encompass essentially every ophthalmic service. And the fiscal savings are significant, as this slide indicates. In fact, there's more data and more studies that have come out in the last year. The Inspector General reported just a few weeks ago that if hospital rates were reduced to ASC levels for patients with low or no risk, savings could be as high as, get this, $15 billion for the government and $3 billion for the beneficiary over the next several years. To give you some sense of perspective, the entire ASC budget in Medicare is only $3 billion a year. A University of California, Berkeley study concluded that ASCs could save even more, up to $60 billion over the next decade, and cataract alone would account for $800 million in savings. And another study by the University of Louisville, and this was not paid for by the ASC industry. ASCs perform services cheaper and faster. ASCs deliver better outcomes, and the vast majority of patients who receive care in the hospital do not present more complex cases, more resource-intensive cases. They also found that patients were less likely to be admitted to a hospital within 7 days if they originally had their care provided in the ASC. Well, why is Congress interested in this? Well, our policymakers need money to stave off greater Medicare budget deficits. And, this is important, to pay for big-ticket items like the SGR fix. And indeed, it was in the context of Congress almost coming up with a permanent fix last year that this proposal to level the playing field between the hospitals and the ASCs gained some momentum. I think we're going to see a lot more of this in the days ahead. Well, why do we care if hospital rates are reduced and our rates are not increased? I mean, wouldn't it be a real win to have our rates increased to the hospital levels? That isn't going to happen. It's way too costly. But I submit that we accomplished something very, very important, that hospitals are not particularly enthusiastic about taking on eye cases. At least that's what you've been telling us. So how interested are they going to be in performing these cases when their payment rates drop from $1,700 to under $1,000 for a cataract, or from $3,500 to $1,800 for a VR case? Where are these cases going to go? This is a volume proposition for the ASC. You're going to get many more cases, and the economic impact is going to be considerably greater than getting a point higher in our inflation update. So if the playing field is leveled, I think we're also going to have a much better argument for receiving the same hospital market basket update rather than the lower CPIU that we currently receive. This is going to stem the insidious tide of hospitals buying ASCs, converting them to hospital outpatient departments in order to receive the same payments. And perhaps most importantly, being on the same field at the same level, hospitals and ASCs will have the very same interests in seeking higher payments. Wouldn't it be nice to ride the hospital industry's coattails with their big lobbying forces and budgets? I think it would be fantastic for our facilities. Another issue has come up of late, and that is cost reporting for ASCs. The Medicare Payment Advisory Commission has recommended that ASC costs be reported or surveyed. CMS believes that this isn't necessary, and we believe absolutely positively no cost reporting. Since our underlying rates are linked to the hospital outpatient department, and our update is as well, there's no reason for us to go through what is a very, very heavy and unnecessary administrative burden. Quality reporting. Quality reporting is truly the new horizon in the regulation of ASCs. I've spoken to many OOSS members who to date have felt like the first 18 months of quality reporting has gone smoothly. It has not been particularly burdensome. Well, is the current program working? Well, what's incredible is that 98% of ASCs are in compliance with the quality reporting measures. But we are increasingly troubled as CMS and others have moved from those general across-the-board ASC measures towards specific ophthalmic measures. A couple of examples. The Measures Application Partnership recommended at first that we report, that ASCs report on high acuity care visits to hospitals, meaning ER-type visits, that take place within 7 days after a cataract procedure. That we were able to get deferred, I think, indefinitely. CMS proposed last summer that ASCs report on complications within 30 days following cataract surgery. That was proposed and withdrawn. But Measure ASC 11. They have proposed last year that we report on the visual function improvement within 90 days of surgery. It was proposed, it was finalized, and we were successful in getting it delayed until January 1, 2015. But it's not gone yet. And I do believe that CMS will, within the next couple of weeks, propose a revised version that they think will not be so difficult to operate. Our guiding principle is very simple. Any ASC measure must relate to the episode of care in the ASC. It must be collectible by the ASC staff. It must produce conclusions that are actionable by the ASC, and the measure has to have been reported in the ASC, or tested in the ASC. That was not the case with ASC 11. It's going to continue to be a problem, and we will fight it vigorously. Now, last year, that delay that we received came about because OOSS partnered with a number of other organizations, the other eye groups, and the ASC Association. We even worked with the hospital industry because they were subject to this rule as well and would have had even more challenging difficulties in complying. These efforts will continue. We will mount, again, a robust educational effort to make sure that you are updated in real time, and we'll provide assistance in compliance. And we're even working right now on a tool. We're working with an outside vendor on a tool that will help you comply with ASC 11 and any other mischief that comes out of CMS by automating data collection and facilitating submission to QualityNet. And we're going to come up with something, hopefully, that is not going to be particularly costly. So what are we going to do with you? We're going to work with CMS and others to ensure that measures are reasonable and manageable. We will sponsor webinars and develop materials that will enable you to comply. I'm pleased to report that hopefully within a year, the ASC Quality Collaboration will have developed a registry that will greatly assist us in this process. And again, the tool that I talked about earlier. What we really need, though, are better measures, better ophthalmic measures, measures that make sense. And this is a major effort being undertaken by the three ophthalmology organizations, by the ASC Quality Collaboration, and by the ASC Association. What we've got under consideration are a few that I'll share with you without getting into a lot of detail. One is that wrong IOL implant. Right now there's a measure for wrong site, wrong side, wrong anything that happens in an operation in an ASC. But the data isn't segregated by type of facility or procedure. So when all is reported, nobody has any sense of whether the problem was in the eye facility or not. We also think that unplanned vitrectomies make sense, and perhaps the best measure of all would be to report on TAS. The key to making this quality reporting program work, not just to be manageable, but to generate data that will improve care in the facility, is to have better measures. And again, what should those standards include? The measure must relate to the episode of care that takes place in the facility, is collectible by the ASC staff, produces conclusions that are actionable by the facility, and have been tested in that facility setting. And these ones that we are proposing fit those characteristics. There's another little bit of mischief that we've talked a little bit about in the communications we've had with our membership, and that is that CMS is developing an ASC outcome satisfaction survey. Now, in one of the surveys we've done of our members, we've discovered that typically, response rate isn't that great anyway, but the best number of survey questions is perhaps a dozen, no more than 15. Well, I don't know if you took a look at this draft survey that CMS circulated, that we transmitted out to you. Their survey would include 47 items. It makes no sense. Patients will not respond, and the effort will have been a waste. We'll continue to work to make changes there. Another very, very troublesome issue that we encountered over the past year is the activities of the Facility Guidelines Institute. These are the folks that develop architectural guidelines for ASCs. There were a number of very troubling elements to their 2014 proposal, the most significant of which was that the minimum OR size for any ASC would be 360 square feet. We did a survey of our members and discovered that close to half of our facilities wouldn't even meet that test. I'm pleased to report that FGI modified its proposal, and the final regulation sets a minimum standard at 250 square feet. Now, do we really care about this? Technically speaking, these guidelines apply only to new facilities. However, it's important to keep in mind that existing ASCs can be implicated if, for example, you seek a certificate of need to add an OR. You might be viewed as a new facility and subject to these requirements, or if you transfer ownership to the ASC. Could be bad news when you're trying to let go of to sell your facility to somebody else. So I've outlined quite a few of our priorities, quite a few of our activities. I'm pleased to say that we have succeeded, at least temporarily, on a number of fronts. Ultimately, we need some legislative reform to keep CMS in the right place. And you'll receive information from us in the months ahead asking you to contact your congressman to support the Ambulatory Surgical Center Quality and Access Act of 2013. This legislation is important. It would mandate that CMS provide us with the same annual update as hospitals. It would provide for a more rational quality reporting program. It would require that just as we are penalized if we don't report, we should receive bonuses if we do report and have high-quality results. And that's value-based purchasing. This is an important piece of legislation, and we hope you'll help out. Our agenda is dynamic, as you can see. We were successful in delaying ASC 11, knocking out a number of other measures, getting the Facility Guidelines Institute architectural guidelines modified. We're making progress in seeing the rates between hospitals and ASCs equalized, which will be a significant volume proposition and benefit for the ASCs. And there's more where that came from, and we'll continue to report to you. So the question I have to ask you is this. Are you helping out the community? OOSS is the last line of defense on ophthalmic ASC issues. We very much appreciate the efforts of the AAO and the ASCRS. But these issues, the ones I've been addressing, are our sole reason for being. If we don't do the work, the job doesn't get done. We are a small but dynamic group, but we have very limited resources. It's important that every ophthalmic facility join OOSS, and yet a relatively small percentage are members. If you are not a member of OOSS, please join. If you're already a member, please consider joining the President's Council. We're going to give you tools to help you develop relationships with your legislators in the years ahead so we can become even more successful. And we hope you'll consider contributing to the Outpatient Ophthalmic Surgery Society Political Action Committee. Political action is not a four-letter word. We need to play in the same arena as the hospitals. I very much appreciate your attention and look forward to staying in touch.